Welcome, deep divers. Today, we're jumping right into the musculoskeletal system. We're aiming to cut through, some of the dense stuff you find in textbooks.
Exactly. We're using Lewis's Medical Surgical Nursing, the 12th edition, as our guide.
Right. And our mission today is pretty clear. Take this foundational, sometimes complex topic and make it really accessible, really actionable for you as nursing students.
We want to help you build insights for your clinical practice and, yeah, definitely for nailing those NCLEX questions.
We'll be hitting the key areas: pathophysiology,
Mhm.
assessment, management, all the essentials.
And what's really foundational here, I think, is that this system, it underpins just about everything related to patient mobility, their functional ability, and crucially, their safety.
That's a great point.
So our goal isn't just memorization, it's about understanding the what and the why. Why does this condition present this way? What's the rationale behind this assessment technique?
So you can connect those dots in real patient situations.
Precisely. And to help us do that, we're going to follow a case study throughout our chat today. Her name is GA. She's a 58-year-old woman, and she comes in with acute pain in her great toe.
Okay, GA will be our guide. So let's start with the absolute basics. What exactly is the musculoskeletal system made of, and what are its big jobs?
Well, fundamentally, you're looking at voluntary muscle working together with several types of connective tissue. Think bone, cartilage, ligaments, tendons.
Fascia, bursae, too.
Exactly. And the functions are, well, profound. Bone gives us that structural framework, supports our weight.
And protection, like the skull protecting the brain or the ribs.
Shielding the heart and lungs, yeah. Plus, bones act as levers for muscles, making movement possible. And let's not forget the bone marrow inside, that's where blood cells are made.
Hematopoiesis.
Right, and they store crucial minerals, calcium and phosphorus mainly. That impacts so much more than just bone strength itself.
It's amazing how dynamic bone is, too. It's not just this static scaffolding, is it?
Not at all. It's constantly undergoing remodeling. There's this continuous process of breaking down old bone and building new bone. It happens throughout our lives.
That's the resorption and ossification process.
Exactly. You have osteoclasts, the cells that break down or resorb old bone tissue. Then the osteoblasts come in. They're the bone-forming cells laying down new matrix. That's ossification.
Understanding that balance is key, especially for conditions like osteoporosis later on.
Absolutely. When that balance gets thrown off, you see problems.
So if we picture a typical long bone, say the tibia,
Okay.
at the ends, you've got the epiphysis, right?
Yeah.
Those widened parts covered with articular cartilage for smooth movement in the joint.
Mm-hmm.
The main shaft is the diaphysis, mostly compact bone, giving it strength.
Provides that core structural support.
And in kids, there's that crucial bit in between, the epiphyseal plate, the growth plate.
Ah, yes, vital. That's where longitudinal growth happens, an injury there in a child. It can actually stop the bone from growing longer.
Leading to limb length differences, something you might definitely see in practice.
And covering the bone, except where the cartilage is at the joints, is the periosteum. It's this fibrous layer, really important for nutrition and muscle attachment.
Then inside, the medullary cavity with the marrow. Yellow marrow in adults, mostly fat storage.
Right, in the shaft of long bones. While the red marrow, where that hematopoiesis happens, is more in flat bones like the pelvis and the ends of long bones.
Got it. So from the solid structure of bone, let's shift to things that allow movement and cushioning. Joints and cartilage.
Yeah, the unsung heroes maybe? Joints or articulations are simply where two bones meet. They allow movement but also provide stability.
And for nurses, the ones we deal with most are the freely movable ones, the synovial joints.
That's right, diarthrodial joints, they're more complex. They have a joint capsule, a synovial membrane lining it that produces synovial fluid.
Which is key for lubrication, right? Reduces friction, nourishes the cartilage.
Exactly. That articular cartilage covering the bone ends relies on it. And then you have ligaments and tendons reinforcing the whole structure.
Think about those basic movements we assess all the time. Flexion, extension, abduction.
Mm-hmm.
Your elbow is a good example of a hinge joint, just flexion and extension. But your shoulder, that ball and socket.
Gives you that huge range of motion. So when you're assessing a patient's mobility, you're literally watching these joint types in action, looking for pain or limitations.
And the cartilage itself, the articular cartilage, it's avascular.
That's a critical point. No direct blood supply. It gets nutrients by diffusion from that synovial fluid.
So the clinical takeaway is
Slow healing. Really slow. When cartilage gets damaged, repair is a very gradual process. Helps you manage patient expectations about recovery time.
good point.
Okay.
Engines of movement now.
Hmm.
Muscles, specifically skeletal muscle, the ones we control.
Right. Skeletal muscle makes up a huge chunk of our body weight, almost half. Inside the muscle fibers are myofibrils, and these are made of sarcomeres.
The basic contractile units.
Exactly, with the actin and myosin filaments that slide past each other to create the contraction.
And the trigger for that is the neuromuscular junction,
Yep. A nerve impulse arrives, releases acetylcholine,
which causes calcium release inside the muscle cell,
and that calcium influx, that's the spark. That's what initiates the actual muscle contraction.
which also explains why low calcium can cause problems like tetany, those involuntary contractions.
Precisely. And energy-wise, ATP is the direct fuel source for that contraction.
Okay, and what about different types of contractions?
We often talk about isometric, where the muscle tension increases, but there's no joint movement, like holding a weight still or plank,
Right.
versus isotonic, where the muscle shortens and produces movement, like lifting that weight. Most activities mix both.
And as nurses, we see the impact of disuse, muscle atrophy, shrinking, and activity, which leads to hypertrophy or growth.
Absolutely. It directly informs how we approach mobilizing patients' rehabilitation.
Then quickly, ligaments connect bone to bone, tendons connect muscle to bone. Both tend to heal slowly, too.
Yes, similar to cartilage in that they have a relatively poor blood supply compared to muscle or bone. Slow healing is a factor there, too.
And bursae, those little sacs.
Fluid-filled sacs, usually near bony prominences. They're there to reduce friction. When they get inflamed, that's bursitis. You'll see patients with that localized pain, swelling.
Okay, we've covered the structures,
Yeah.
but one of the biggest factors influencing this system is time. How does aging affect all of this?
Oh, the effects of aging are significant. It's a major contributor to functional decline in older adults.
What kind of changes are we talking about?
Well, with bone resorption, the breakdown starts to outpace formation. This leads to a net loss of bone density.
which is osteopenia and can progress to osteoporosis.
Exactly. Muscles also take a hit. There can be a pretty significant decrease in muscle mass and strength, maybe 30% loss by age 70.
Wow, 30%.
Yeah. And connective tissues, the ligaments and tendons, they become less flexible, stiffer, movement gets more rigid.
And joints.
Increased risk for osteoarthritis. That protective cartilage wears down over time.
So as nurses, what are the visible signs we should look for? Things that are, let's say, expected changes versus signs of actual disease.
Good distinction. You might see some loss of height, maybe an increased thoracic curve, that kyphosis or dowager's hump, often with some back pain or stiffness.
Joints might feel stiffer, have less range of motion, maybe some crepitation, that crackling sound.
Definitely. And muscles will likely show decreased strength and mass. You might see the abdomen protrude a bit more as muscles weaken. Agility decreases, fatigue sets in faster.
But the key is distinguishing these somewhat expected changes from something treatable that's causing excessive symptoms.
Absolutely. And a critical safety point here. All these changes, weaker muscles, altered balance, changes in proprioception, which is your sense of body position.
They all add up to a much higher risk of falls in older adults.
Huge risk. Fall prevention becomes a massive nursing priority. And for our case study patient GA at 58, these changes might be just starting, making that assessment really vital.
Right. So knowing the structures and how they change, how do we start gathering information from a patient? Let's pivot to assessment, starting with the subjective data, what the patient tells us.
That subjective piece is absolutely crucial. You're asking about those common signs. Pain, weakness, any deformity they've noticed, stiffness, limitations in movement, maybe that crepitation.
Ask about changes in sensation too, numbness, tingling.
Definitely. And muscle size changes. Then you dive into their health history. Any history of arthritis, gout, lupus, osteomyelitis, any past infections that could seed into bone.
What about indirect things, like diabetes or thyroid problems?
Good point.
Right.
Yes, conditions like diabetes, parathyroid issues, even polio history can impact the musculoskeletal system. Always ask.
And trauma history is big. Need a clear timeline. What happened, treatment received, how it affects them now.
Exactly. Do they use assistive devices? How does it interfere with their daily life, their
All
ADLs?
medications. We need a complete list.
Absolutely complete. Muscle relaxants, opioids, NSAIDs, steroids, calcium, vitamin D, all of it.
Plus, we need to flag meds known to cause problems, right?
Right.
Like anti-seizure drugs potentially causing osteomalacia.
Or corticosteroids leading to a vascular necrosis. And for GA, we already noted her hydrochlorothiazide, a potential trigger for gout. That's a key link.
Okay, then we use the functional health patterns to get that bigger picture, how this impacts their whole life.
Right. It's a structured way to explore things. Like under health perception health management, you ask about their usual practices for staying healthy, body mechanics, safety habits at work or home.
Genetic risks too, family history of things like RA, osteoporosis, gout.
Yes, that's important under this pattern too. Then nutritional metabolic.
Mhm.
What's their diet like? Calcium, vitamin D, protein intake, any issues preparing food? Is their weight putting stress on joints?
Elimination?
Yeah.
And they get to the toilet. Okay. Constipation from immobility.
Activity exercise. How does this affect their ADLs? What's their usual exercise routine? Any pain, weakness, crepitus during activity? What about their job? Repetitive strain?
Sleep rest. Does pain wake them up? Do they need special pillows or bedding?
Cognitive perceptual. We need a good pain assessment here. That 0-10 scale. How do they manage pain? Heat, cold, alternative therapies. Any joint swelling or muscle weakness they perceive?
Self-perception. Self-concept. How do deformities or limitations affect their body image or self-worth?
Role relationship. How does it impact their roles? Parent, employee, spouse, who helps them? Do they need support services?
Sexuality, reproductive. For women, menstrual history is relevant. Early menopause is a risk for osteoporosis. Does pain affect intimacy?
Coping stress tolerance. How do they deal with the stress of pain or limited mobility? And value belief. Any cultural or religious beliefs affecting treatment choices?
Okay, pulling this back to GA, her subjective story had some real red flags. What jumps out at you?
Well, several things. Her age, 58. Comorbidities like hypertension and type 2 diabetes. That significant smoking history, 40 pack years, and she's still smoking daily. Plus nightly alcohol.
Lifestyle factors.
Big time. Her BMI is 29.3, so overweight heading towards obese. She avoids dairy-think calcium intake and is minimally active.
Another presenting complaint.
That acute onset, 8 out of 10 sharp breening pain in the left great toe. And she specifically asks for strong pain meds. That tells you the severity.
And the hydrochlorothiazide again?
Yep, that diuretic is a known potential trigger for gout flares. So putting it all together for nursing priorities, number one is pain management. Then you're thinking fall risk, given her inactivity and potential pain. And huge patient education needs around lifestyle, diet, meds.
Okay, so that's what she tells us. Now, what can we see and feel? The objective physical assessment.
Right. This involves inspection, palpation, checking neurovascular status, range of motion, muscle strength, usually done systematically head to toe.
Inspection starts with just looking, right?
Yeah.
General appearance, posture, how they walk.
Exactly. Observe their gait. Is it smooth? Or are they limping an antalgic gait due to pain? Maybe staggering, an ataxic gait. Look at body build, muscle symmetry, joint contours. Any obvious swelling, redness, deformity, always compare one side to the other.
Then palpation, using warm hands.
Always warm hands. Feel for skin temperature, tenderness, swelling. Can you feel any crepitation in the joints or muscles? Get a sense of the underlying structures.
Next up is motion, range of motion or ROM.
We look at active ROM, what the patient can do themselves, and passive ROM, where you gently move the joint through its range.
But be careful with passive, right? If there's pain or resistance.
Absolutely. Never force it. You could cause injury. Again, compare sides. Is the ROM equal? Sometimes we use a goniometer for precise angle measurements, but often comparing to the unaffected side is practical.
And muscle strength testing, that 5-point scale.
Right. 0 is no contraction at all. 5 is normal strength active movement against full resistance. We test major muscle groups, again comparing sides. Is the dominant side slightly stronger? That's normal.
We might also take measurements, like limb length or muscle circumference.
Yes, especially if we suspect atrophy or swelling. The key is consistency. Mark the exact spot you measured so follow-up is accurate.
What about other specific checks, like scoliosis?
Important, especially in adolescence, but relevant throughout life. Look for that lateral S-curve in the spine, unequal shoulder height. Have them bend forward, that often makes it more obvious. Severe curves can even affect breathing.
And the straight leg raising test.
Useful for back and leg pain or sciatica. If raising the straight leg causes pain down the leg, especially below the knee, it suggests nerve root irritation, often from a herniated disc.
Okay, let's connect this back to GA. What did her objective assessment show?
Her vitals were mostly stable, though BP was a bit high at 1 to 894, and respiration's a bit fast at 26. She was alert. lungs clear.
Above the foot.
That was the key finding. Her left great toe was visibly red and swollen. No open wounds, but described as having tremendous pain on palpation and with any movement at all. Her pedal pulses were a bit weak, +1 bilaterally.
So localized inflammation, severe pain, specific joint.
Exactly. It fits perfectly with her subjective report and those risk factors we identified. It's all pointing strongly in one direction.
To really nail down the diagnosis for GA and others, we need diagnostic studies. What are the go-to tests?
Imaging is usually first. X-rays are the workhorse. They show bone issues like fractures, deformities, density changes.
Pretty standard.
Then you have CT scans. Great for more detail on bone and some soft tissues, especially in trauma. Remember kidney function checks and contrast allergies if contrast is used.
And MRI.
Even better for soft tissues, ligaments, tendons, cartilage, discs. Excellent for things like a vascular necrosis or tumors. Big safety checks here. No metal implants, screening for claustrophobia.
What about fluid from the joint itself? Arthrocentesis.
Hugely important, especially when infection or crystal-induced arthritis like gout is suspected. We aspirate synovial fluid from the joint.
And what are we looking for in that fluid?
Normal fluid is clear, maybe straw-colored, not much of it and not thick, but abnormal findings tell the story. Cloudy, purulent fluid points to infection.
And a whitish yellow.
That strongly suggests gout. Blood indicates trauma or bleeding disorder. And under the microscope, finding specific crystals is key. Uric acid crystals mean gout. Calcium pyrophosphate crystals mean pseudogout. We also do gram stains in cultures if infection is suspected.
Are there other key diagnostics? Bone scans? Blood tests?
Sure. A bone scan uses a radioisotope. Areas of high bone turnover, like an infection, tumors, or healing fractures, show up as hot spots. Requires the patient to lie still.
DEXA scans for osteoporosis.
Right, measures bone mineral density. And blood tests or serology studies are vital. Things like C-reactive protein, CRP, for inflammation, rheumatoid factor, RF, or anti-CCP for rheumatoid arthritis, calcium, phosphorus, alkaline phosphatase for bone metabolism, creatine kinase, CK, if muscle damage is suspected.
Okay, moment of truth for GA. What did her diagnostics show?
This is where it all came together. Her foot x-ray was pretty unremarkable, just minor soft tissue swelling, no fracture, maybe very mild arthritis changes, but nothing acute.
So the x-ray didn't scream gout.
Not definitively, no. Her basic blood work, CBC, electrolytes were all normal.
But the arthrocentesis.
That was the key. They aspirated fluid from that painful big toe joint. The fluid itself looked clear, protein and glucose were normal.
Right.
But microscopic analysis showed definite urite crystals.
Bingo.
Bingo. That finding, combined with her clinical picture, the acute severe pain, the redness and swelling in that specific joint, her risk factors like the diuretic confirms the diagnosis. It's gout. It's a perfect example of putting all the pieces together.
So we have the diagnosis. Now, pulling everything together, structure, function, assessment, diagnostics. What does the nursing management look like for someone like GA?
It starts with that thorough assessment we talked about, using all that subjective and objective data. From there, we identify the priority nursing interventions.
For GA, pain is number one, right?
Absolutely. Aggressive pain management. That likely involves medications, probably NSAIDs or colchicine initially for the acute gout flare, but also crucial non-pharmacological measures.
Like ice. Elevation. Rest.
Exactly. Proper application of ice to reduce inflammation and pain. Elevating the foot to help with swelling. And strict rest for that affected joint during the acute phase is vital to prevent further irritation.
And beyond GA, for other musculoskeletal issues, mobility is often a focus.
Huge focus. Assisting with range of motion exercises, teaching proper body mechanics, ensuring safe use of assistive devices like walkers or canes, and constantly assessing and implementing fall prevention strategies.
Controlling inflammation or infection if that's the underlying issue.
Right, based on the diagnosis. And nursing is central to collaborative care. We're working closely with physicians, PT, OT, maybe dietitians.
For GA, that collaboration might involve discussing dietary changes, reducing purines.
Definitely. And talking about alcohol intake, weight management, medication adherence, making sure she understands why she needs to take her meds regularly, not just during a flare.
Which leads us to patient education. Sounds critical here.
It's the cornerstone for long-term success, especially with chronic conditions. You need to explain the condition itself. What is gout? What triggers it? How is it managed?
Medication teaching too. Purpose, side effects, timing.
Absolutely. Lifestyle modifications, diet, exercise recommendations tailored to her abilities, smoking cessation, limiting alcohol, reinforcing safety measures, helping patients develop coping strategies for dealing with chronic pain or limitations.
And circling back to those terms we discussed, osteopenia, kyphosis, crepitation, making sure patients understand what they mean in relation to their health.
Yes, empowering them with knowledge is key to adherence and self-management.
This really paints a picture of how everything connects from basic anatomy to complex diagnostics to hands-on nursing care. It's truly comprehensive.
It really is. So, to quickly recap the main takeaways for everyone listening. First, that solid understanding of musculoskeletal structure and function is your foundation.
Mhm.
Second, a thorough subjective and objective assessment, including those important age-related considerations, is absolutely critical for identifying
Clear.
problems.
Don't skip the details.
Never. Third, diagnostic studies, like that synovial fluid analysis for GA, are powerful tools to pinpoint specific conditions.
They give you the confirmation you need.
And finally, the nurse's role is absolutely central in assessment, prioritizing interventions, collaborating with the team, and perhaps most importantly, in patient education. Applying that critical thinking, that clinical reasoning, is how you provide effective care.
Fantastic. As you all head towards your exams and into your future practice, just remember that understanding these connections, every detail, is what makes you an informed, effective, and compassionate nurse. And here's something to ponder as we wrap up. How might a deeper understanding of bone remodeling in specific populations, maybe beyond just the aging process, impact future preventative nursing interventions?
Good question to think about.
A warm thank you from the Deep Dive team. We'll catch you on the next one.